Aloha everyone! Welcome to this lecture in which we are going to cover Chapter 8, which is all about your joints. So just in case you're wondering, okay, why is this topic important? Well, who likes to move? Because you can thank your joints for being able to move. So we're able to move our bodies because our muscles contract across joints, moving one bone towards another bone. So joints are going to be any areas where two bones meet, and we also call that articulate when they come and meet. And we actually have more joints in our body than we do bones. So today we're going to be learning all about our joints. So for this Chapter 8 lecture, we're going to be talking about the functions of joints. So we're going to explain how the functional and anatomical classifications are related, which is essentially, if we look at the different classifications, we can either look at what they're made of, or we can look at how much they move, whether they don't move at all or whether they move a lot. So that's one of the first things that we're going to go through in this lecture. Then we're going to describe the anatomical classifications. So that's what they're made of. That's whether they're fibrous, cartilaginous, or synovial joints. And then we're going to go over some examples of each. So we're going to be talking a lot about the different types of synovial joints and where they are and how they function in the body. So a good chunk of this lecture we're going to spend looking at synovial joints and the characteristics that make them unique. At the very end of this lecture, I'm going to show you a table from your e-text that gives you the actual names of the joints. And we're going to go through those more if you are in a lab class. But in this lecture itself, I don't go through the names of the different joints. We more so focus on the characteristics and the different types of joints, but you are still going to be expected to know those key joints that we'll talk about at the very end of lecture. So let's go ahead and get started. So joints are also known as articulations, right? I've used that word a lot already this semester. When something articulates, it joins together, that is a joint. So when things are articulating with each other, they're coming together and they're joining at a certain part. So anytime that something meets or touches something else, it means that it's articulating with it. So arthrology is going to be the study of joints, whereas kinesiology is going to be the study of motion, right? So the articulation, that's where that joint, it's what joins them. So arthrology, you're studying the actual joint itself. And then kinesiology is the actual study of the movement of our body through these articulations that are part of arthrology. So that's how these two studies are related. And again, articulation, that's a joint. And the function of our joints is to give the skeleton mobility and also to help hold our skeleton together. So at the very beginning of Chapter 8 in your e-text, it talks about how there are two different classifications of joints. So we have a functional classification that's based upon the amount of movement that is allowed from that joint. Then we have the structural classification, and that's going to be based on the type of material that that joint is composed of. So for the functional joints, we have immovable joints, meaning they cannot move. That's going to be synarthrosis, is the technical name for that. Slightly movable is going to be amphiarthrosis. So I like to tell students, remember amphibians, they live both on land and in the water, right? So amphibi means both, right? So they're moving back and forth between the two. So amphi is not fully movable, but not immovable. It's kind of the in-between there. So slightly movable is amphiarthrosis. And then we have freely movable joints, and these are diarthrosis joints. So usually, this is kind of summarizing it a bit too much, but for the most part, what we find is that the appendicular skeleton, so our appendages, that pectoral girdle, our pelvic girdle, that's going to mostly consist of these diarthrosis joints. And then the axial skeleton, so our vertebral column, our our skull, kind of this middle portion here, that's mostly going to have synarthrosis, so immovable, as well as slightly movable or amphiarthrosis joints. And really, if you think about that, that makes sense, right? The middle, this axial skeleton, is used for stabilization, right? We don't want those bones to be movable. Whereas our appendages, we want to be able to move those, right? So appendicular skeleton is mostly these diarthrosis joints. And then in terms of the axial skeleton, they're going to be synarthrosis and amphiarthrosis. What you're going to notice if you've read through your e-text, though, is that there's not a lot of talk about the functional classifications. Mostly the focus is on these structural classifications. And the structural classification is going to be based on the presence or absence of what's known as a synovial joint cavity and the type of connecting tissue that joint is composed of. So we can break the structural classifications down into fibrous, cartilaginous, and synovial. And we're going to be defining these all today and looking at examples of them. So synovial joints are going to be the most movable. So they are diarthrosis joints, right? The cartilaginous, think of, they're made up of cartilage, right? These are the ones that are going to articulate with cartilage. And then the fibrous, these are going to be, they have short fibers, so they can increase that amount of movement. For the most part, we see that the fibrous and the cartilaginous joints are going to be immovable or slightly movable, whereas the synovial joints are going to be those that allow the most motion. So you'll notice that for the rest of this lecture, we're mostly going to be focusing on this number 2 here, these structural classifications, because the structural classifications are much more clear-cut and easier to understand. So that's why we're going to focus on them in this lecture. And again, you'll also notice that's what your e-text focuses on. But as we go through these structural classifications, I will mention to you, hey, this structural type is generally going to be immovable or slightly movable. So we're going to add in these functional classifications. We're just going to walk through it by looking at the different types of structural classifications. So we're going to start off by looking at these fibrous joints. So as I mentioned on the previous slide, today we're going to be covering the different types of structural joints. And we're going to begin with looking at the fibrous structural joints. So when we look at these fibrous joints, the fibrous joints are going to be bones connected by very dense fibrous tissue. So there's really no joint cavity in these fibrous joints. And we're going to talk more about cavities when we get into the other types of joints. But because they're mainly immovable, they don't have a cavity to move around. And when we talk later about synovial joints, you'll see why that cavity is so important. So again, no joint cavity for these fibrous joints, and they're mostly going to be immovable. There are 3 different types that we're going to break down fibrous joints into. So there are sutures, which we talked a little bit about. We're going to look more at those. We have our syndesmoses, and then we have gonphomoses. So we're going to look more in the following slides at these 3 different types of fibrous joints. I'm going to give you examples of them as well. So the first type of fibrous joints that we're going to talk about are these sutures. And you probably remember me mentioning these sutures back when we talked about the skull, right? Sutures literally mean seams, and you can see them really well in our skull, right? They look like little kind of zigzag notches here. And those are actually a type of fibrous joint. So sutures, suture literally means seams, and sutures are only going to happen between bones of the skull. So this is the one area of our body that we actually see it. They're going to be wavy, articulating bone edges that essentially interlock, right? If you look at this kind of zoomed in image here, you can see it kind of interlocks like a puzzle piece. And they're joined by minimal amounts of very short connective tissue fibers. So you can see that here, this fibrous connective tissue right in there in that suture line. So when you are a child, you're going to have larger sutures that end up coming together during your middle age. Then during middle age, that fibrous tissue is going to ossify, and our skull bones are going to fuse into a single unit. The closed sutures are then called synostoses. So these are going to be bony junctions. And the movement of the cranial bones would damage the brain, right? We don't want our cranial bones to be moving. So it's really important that these sutures are immovable, right? The immovable nature of our skull is actually a protective adaptation that happens over time in order to protect our brain. So you can see here the difference. This is the sutures in an infant or child. This is showing you the lateral view and a superior view. You can see how they're much bigger, right? For a child, you have larger sutures. They're going to come together again during middle age and become much smaller, like this in this adult skull. And again, once in middle age, when we get those closed, immovable sutures, those are known as synostoses. So I mentioned that those sutures are larger when we're children, right? And then once we get to middle age, they're going to come together, close up, and ossify. So what do you think happens if that suture ossifies too early? And I will warn you, it's a little bit of a graphic picture coming up in order to answer this question. Here is what happens if a suture ossifies too early. So this right here on the left is the normal cranium of a child. Over here on the right is a disease called sagittal craniocytosis. And it's called sagittal because notice this suture has closed way too early, right? It should look like this, and that's completely closed along that plane. So this is the most common type of craniocytosis, again, sagittal craniocytosis. And it accounts for about 50% of all craniocytosis cases. And its prevalence is actually more common than you would think. It is 1 in 2,000 live births. So this happens a lot. And you can see that through that sagittal line, that sagittal suture that we talked about earlier, these bones have fused. They're going to fuse really early on, right? And when it fuses, the bone starts to grow and grow. And as you can see, it kind of starts to push on these other sutures as well. So again, this is going to be right over here, sagittal craniocytosis. So as a result, what you get then is kind of this misshapen skull, with the actual shape of that skull depending on which of the sutures are affected. So there's kind of, if you feel that skull, if you palpate it, there's going to be this abnormal feeling to it. And you can also kind of see a disappearing fontanelle on the baby skull. Oftentimes there's a development of this kind of raised hard ridge along that affected suture, because there's going to be slow or perhaps even no growth of that head as the baby grows. We also see what you can kind of see in this picture, the frontal bossing, right? You can see how pronounced the forehead is right there. The other thing you often see is the exaggerated occiput, right? And that results in, this is known as kind of boat skull appearance. So think about it, if this was to happen to a child, what problems do you think that child might encounter? So this can, one, not allow the brain to grow properly, right? So the increased anterior posterior skull length is going to result in it's going to result in it not being able to accommodate that growing brain as it should. So then we notice that the brain development is not occurring as it should as well. So Thankfully, there is a low risk of abnormal brain growth and development once this issue has been fixed. And it's a lot easier to fix this issue when the child is young. The way that they fix this is they can actually go into that suture and they can start to break it up. They break apart that bone and reconstruct it. So it's much easier to do when the child is young, whereas when they're older, it's not as easy to fix because those sutures are already closed up. So to try to break those open is much more dangerous. So yes, this sagittal synostosis or sagittal cranial cytosis can be fixed, right? Again, it's much easier when the child is young. And here are some of the befores and afters. So you can see before, after here. This one down here I think is a little more pronounced. You can definitely see that frontal bossing. And this is after surgery over here. So that's kind of gives you an idea about why these sutures are important, why we want them to fuse at the correct time, and what can happen if we do have a case of craniocytosis. Again, need surgery to go in and break up that fused suture and reconstruct it so it's able to form properly. So we finished talking about that first type of fibrous joint, which is your sutures. So next, let's move on to syndesmoses. And these are going to be bones that are connected exclusively by ligaments. And to help you kind of remember this, syndesmos actually means ligament. And these ligaments are going to be cords or bands of fibrous tissue. I know we've talked about ligaments before, but I didn't give you a technical definition. So anytime we talk about ligaments, they're going to be those cords or bands of fibrous tissue. The amount of movement that occurs at these syndesmoses is going to depend on the length of the fibers. So it depends on what area of the body that we're looking at. So if the fibers are short, there's going to be less movement. Likewise, if those fibers are long, like between our radius and ulna, we're going to see that there's a larger amount of movement that can occur there. So the shorter the fiber, the less movement that occurs. So if you think about that, we can turn our arms a lot more than we can turn our ankles, right? So our ankles can't really move as much as our wrists and our arm can. So that's kind of what these figures here are showing you. They're showing you two different areas of the body where we have these syndesmoses. Over here on the left, you're seeing with the radius and the ulna, and this right here is going to be that radial ulnar syndesmoses. So you can see much longer. That allows us to have more movement. On the other hand, over here, this still is a syndesmose, but it's a much shorter fiber. So this is looking at this joint that's held together by this ligament right here. It's much shorter, and that's why we don't see a lot of movement in that region. So short fibers, little to no movement. Longer fibers give you more movement. So those are our syndesmoses. Again, those are where the bone is connected by ligaments. The third and last type of fibrous joint is a gomphosmose. So these are going to be kind of like peg and socket fibrous joints. And we only have one example of these, so it'll be hopefully easier to remember. The only example is the articulation of a tooth with its bony alveolar socket. So gompho, if you break the word down, gompho means nail or bolt. And it's kind of like our teeth are in their sockets, right? They're nailed or bolted there. And these gomphomoses also have a fibrous connection. And in our mouth, because that's the only example that we have our periodontal ligament that's going to be that fibrous connection. So here you can see that alveolar socket right here. You have your tooth in there. And right here is that periodontal ligament. So that's going to be that fibrous connection there. So again, these are gomphomoses, and the only example we find is our teeth, how they're in that bony alveolar socket. Now that we've looked at the three different types of fibrous joints, we're going to move on to looking at the next type of structural joint, which is our cartilaginous joints. So in terms of cartilaginous joints, it's just like it sounds, right? In this case, the bones are going to be united by cartilage. And like fibrous joints, these have no joint cavity. So if you haven't already figured it out, synovial joints are going to be the only type of structural joint that have a joint cavity. Our fibrous joints and our cartilaginous joints do not have a joint cavity. These cartilaginous joints are going to be not highly movable, so we'll see that they could, one type is going to be slightly movable, but for the most part, we don't see a lot of movement associated with cartilaginous joints. And we have two different types of cartilaginous joints. We have synchondroses and we have symphysis. So we're going to talk more in the following slides about these two different types of cartilaginous joints. We'll look at how much they move, if they move at all. We'll look at some examples in the body as well. Okay, so first we're going to look at the synchondroses. Synchondroses literally mean junction of cartilage, and almost all of these are going to be immovable. And what we have is either a bar or a plate of hyaline cartilage that is going to unite the bones. So if we look at some of the different examples of synchondroses in the human body, the first one I want to talk about is the epiphyseal plate. So we talked about this back in chapter 6 when we looked at bone growth, right? We have epiphyseal plates in the long bones of children. These are temporary joints that are going to become synostoses or fusions of bones. So the epiphyseal plates are going to be the ones that start to produce more and more of that bone as the bones grow from the plate area, and then over time they're going to close up and become ossified once we're past that age of being able to grow. So for females, that's around 18 years, males around 21. So this is an immovable joint, again, which makes sense, right? Because it's growing, we don't need it to be moving. So this shows you that epiphyseal plate, and again, that's a temporary hyaline cartilage joint here. Then we have another example here, the immovable joint between the costal cartilage of the first rib and the manubrium of the sternum. So you can see this figure here. Remember the sternum bone that we talked about last chapter? And then we have this joint that's going to join that sternum to this first rib. So that right there, you can see this is that hyaline cartilage, and that is that joint there. And this also is going to be an immovable joint too. So if you think about it, why would you want these synchondroses to be immovable? Because you wouldn't want your ribs to move around, right? Think about it. You want them to stay put. The ribs are protecting the rest of our organs inside of the body. So you don't want them to move around a lot, because if they move around, then the ribs could come in, they could concave, they could puncture something like a lung. They could puncture something else inside of our rib cage. And same thing here for this epiphyseal plate, right? You don't want this to move around, because as we talked about and mentioned in chapter 6, that this neck region right here is incredibly fragile, right? It's the most fragile area of that bone. So if it moves around a lot, it'll make it even more fragile. And instead, we need it to be stable to allow for that growing. So again, this is the first type of cartilaginous joints, your synchondroses. These are going to be immovable. The examples are going to be the epiphyseal plate, and another example here is that sternum and how it connects to your first rib. So that second type of cartilaginous joint is a symphysis joint. So instead of hyaline cartilage, what we see in the symphysis joints is that fibrocartilage is going to unite the bones. Symphysis literally means growing together. So that fibrocartilage is going to be compressible and resilient, and it acts as a shock absorber. But what it's also going to do is it permits movement, because the cartilages are a little bit longer. So examples of these symphyses would be in areas such as those in between your intervertebral discs, right? So these intervertebral joints, as well as the pubic symphysis that is on the pelvis. So if you think about it, these are undergoing a lot of impact, like with your spine. Say you're standing, even when you're sitting, there's pressure put on it. When you're running, when you're walking, anything that you do, pretty much your spine is being impacted. So these are going to have to endure a lot of tension and a lot of pressure. Same thing goes for over here, this pubic symphysis, especially for women when they give birth. This has to undergo a lot of pressure to maintain the integrity of the bones. So this needs to provide slight flexibility, but also be able to endure a lot of impact. Another thing too with this pubic symphysis joint, I don't know if any of you have ever been pregnant, but something that happens is you have a lot of loosening of ligaments and everything to start getting ready for birth. And this becomes a more flexible region that can also lead to a lot of pain. So a lot of women that are pregnant will end up going to physical therapy for just to kind of work on the pubic symphysis region, try to strengthen those muscles, try to get a little bit more stability because your body is preparing for that major event of childbirth. And so things are obviously going to change in that process. And so strengthening this region, helping to get ready for the birth can help a lot of women be a little bit less miserable during that process of pregnancy. So now we're going to move on to that third type of structural joint, which is our synovial joints. And as you probably have realized already, if you've kind of looked through the slides, we're going to spend a lot more time talking about these synovial joints than we spent talking about the fibrous and the cartilaginous joints. So our synovial joints are the most movable joints. It includes all of our limb joints. The bones are going to be separated by a fluid-filled joint cavity. All of them are going to be diarthrotic, which means freely movable. They're going to share similar characteristics, and they're going to allow several different types of movement. And they can actually be classified into 6 different types. We're going to look on the next slide about the general features of synovial joints. Over here in this figure, what you see are the 6 different types of them. So you can see that there is a pivot joint, like between the C1 and C2 vertebra, and a hinge joint, which is our elbow, a saddle joint, which we find between the trapezium carpal bone and that first metacarpal bone. So a lot of times the thumb is a good example of that one. Your plane joint between tarsal bones kind of allows a gliding movement. Your condyle joint, so for example, between your radius and your carpal bones of your wrist, and your ball and socket joint, probably the one we've heard the most about. So things like our hip joint would be that ball and socket. So on the next slide, we're going to focus more on this diagram here, looking at that joint cavity. We're going to talk about the 6 general features that are shared by all of our synovial joints. So again, we're going to go through the different general features of synovial joints. It'll take us a few slides to get through all these. So the first feature I want to talk about is they all have articular cartilage. And what articular cartilage is it is hyaline cartilage that covers, excuse me, sorry about that. It covers opposing bone surfaces. So over here in this diagram, you can see it in blue. So this is going to be that articular cartilage. This up here is articular cartilage in blue. So again, the type of cartilage that it's made up of is that hyaline cartilage, and it's going to cover those opposing bone surfaces. So what this does is it's going to absorb the compression that's going to be placed on a joint, and it keeps those bones from being crushed and helps to reduce friction. The second general feature that all synovial joints have is that they have a joint cavity. And that joint cavity is here in this greenish yellow. This whole region here is this joint cavity that contains synovial fluid. So this joint cavity is unique to synovial joints, and it contains a small amount of synovial fluid. The area is usually really small, as you can see here, but that space can actually be filled up with fluid when there's inflammation. So this is because whenever you're going to undergo inflammation, there's a lot of edema, right? There's going to be vasodilation or dilation of those blood vessels, right? Which means there's going to be more blood rushing to that area, and it can lead to that edema, which means that swelling, which means there's going to be water filling the different cavities of the body, including this joint cavity. So this is because our tissues aren't going to be able to take up any more water due to inflammatory factors such as histamine. But when there's inflammation, there's water that's released, and these joint cavities are going to swell up. So if you've ever looked at somebody's knee or their shoulder or something after they had surgery or after they had an injury and it looks swollen, part of the reason for that is this joint cavity here is going to be filling up with that fluid, because that fluid needs to go somewhere, and this is a place that it's able to go. So again, first two features here of synovial joints, they have that articular cartilage on those opposing bone ends, right here in blue, right? And then you have that joint synovial cavity here in green. The third feature that all synovial joints have is what's known as an articular or a joint capsule. And this articular capsule is going to enclose that joint cavity. So that joint cavity, you can see that here, right? Sorry, wrong thing that I just pointed to. This articular capsule right here. So this is going to be this region that kind of encloses it, right? So that articular capsule, this is the synovial membrane, what I just pointed out. And then you also have this fibrous layer on the outside. So really that articular capsule is double layered. It has two different layers to it. It has this top external fibrous layer right up here, right? That region in white there. And this is made up of dense, irregular connective tissue. And that continues on, if you look, goes all the way down here to the periosteum, right, of the articulating bone. So that's this external layer of our articular capsule. We also have an inner layer of that articular capsule, and that layer is called the synovial membrane. And that's that first area that I kind of pointed out right here, right? So in green right there, that's a synovial membrane. And the synovial membrane is going to cover all the internal joint surfaces that are not already covered by hyaline cartilage. So you notice it stops like this, right? And I kind of went a little bit too far the first time that I drew it, but this synovial membrane would be right in here. The reason why it doesn't go right up here, what's already there? The hyaline cartilage, right? That articular cartilage that we talked about as the first general feature, right? So in blue here is that articular cartilage. We don't need to cover that area. It's already covered. So the synovial membrane in green here is covering the areas that are not covered by articular cartilage. Another function, you can kind of see it listed down here, of the synovial membrane is to actually secrete that synovial fluid that's going to fill up this joint cavity. Which is the next thing that we're going to talk about here, that fourth characteristic. You're probably wondering, what in the world is synovial fluid? So synovial fluid is a slippery fluid that's going to occupy all the free spaces within this joint capsule, right? So this is derived from the filtration from blood flowing through the capillaries in the synovial membrane. So again, the synovial membrane right here, the blood is going to be flowing through those capillaries. And it has this egg white consistency due to hyaluronic acid that becomes thin and less viscous in the joints. So this functions to provide a very slippery film that reduces the friction between the cartilage. So what this does, the reason why this is important, is that it's actually going to prevent the wearing away of joint surfaces and heat from friction. So essentially it's acting like a lubricant. So again, next two features that we just talked about, that articular capsule, double membrane, you have this external fibrous layer, internal synovial membrane that's going to secrete some of that synovial fluid. And then you have your synovial fluid itself, which is a viscous fluid, and it's going to have, it's the filtrate of that plasma and also has hyaluronic acid. It's going to be really important to act as a lubricant. So the fifth feature here that we find in all of our synovial joints is that they're going to have different types of reinforcing ligaments. So we have our capsular ligament. These are going to be thickened parts of the fibrous layer. We have intracapsular. These are going to be deep inside the ligaments, but they're not actually within that joint cavity. And then we have extracapsular. They're going to be outside that capsule region. So there's all these different types of ligaments, and it looks a little overwhelming, probably if you're looking at this picture. I highlighted the different ones that I kind of want you to focus on. So we have our extracapsular. The extracapsular is going to have the collateral ligaments. And then the intracapsular has the anterior cruciate ligament. So the ACL, probably heard of somebody that's torn their ACL before. So that's going to be right here, this anterior cruciate ligament. And then we have as well this posterior cruciate ligament right here. So the anterior one in front, posterior one in back, because this is going to be an anterior view of your flexed knee. So then we have outside that region, we have the extracapsular, fibular collateral ligaments, and the tibial collateral ligaments. So you can see this fibular collateral ligament right here. Again, this is going to be on the outside because it's extracapsular. And then this tibia collateral ligament right here. Whereas these two that we just talked about, the tibial collateral ligament, or the posterior cruciate ligament and the anterior cruciate ligament, notice they're in blue because they're intracapsular. They're inside, right? So they're going to be deep inside the ligaments, but not within that joint cavity. That's why they're highlighted in blue here. So notice that they're deep inside there. And then the extracapsular highlighted in red. So that fibular collateral ligament and this tibial collateral ligament out here. And then the capsular ligaments, these are just going to be another fibrous layer that's actually part of that articular capsule that we just talked about on the previous slide. So we have all of these different types of reinforcing ligaments, and if you think about it, this actually helps to explain why some people are what we call double jointed. So just because they're called double jointed, keep in mind that the people that are double jointed actually have the exact same number of joints as everyone else. They don't have double the amount. What they have, though, is that their joint capsules and ligaments are going to be more stretchy and more loose than normal. So these ligaments, when they're stretched, they're not able to stretch back to normal. So same thing when you take an actual rubber band in your hand. If you stretch it really far, it may not break, right? But it's going to be less tight than it originally was, right? It's not going to go back to normal. It might look normal, but it's going to be outstretched a little bit. So when you do things like try to put your legs behind your head, you're actually stretching out your ligaments. So while it's all fun and cool, like I remember when we were in like elementary school, we'd do things like that, try to see who was the most flexible. And it's fun to try kind of stuff like that, but making a habit out of it, you can actually stretch your ligaments a little too much, and you don't want to put that kind of stress on those ligaments. Especially as we get older, we need to be a lot more careful about doing those kind of things. But again, that fifth general feature is these different types of reinforcing ligaments. We have capsular, extracapsular, and intracapsular. Then that sixth general feature of our synovial joints is that they are going to all have nerves and blood vessels. So they're going to be vascular and they're going to be innervated. So this allows us to get nutrients in, to get waste out, allows for innervation, so allows sensory, being able to feel pain. So in this figure, everything in yellow, I think I've mentioned this before, most figures, if you see something yellow, that's going to be a nerve. And then in red, you're seeing the different arteries, right? This is going to be our posterior view of our leg, so going up that calf region. Over here is our anterior view of our leg. So synovial joints are going to have a lot of sensory nerve fibers that are going to innervate that capsule. Their function is to detect pain and to monitor that joint position or the location of that joint and how much it's stretching. So this helps with sensing our posture and our body movements. The blood vessels are going to be what produces that blood filtrate that again is going to be the basis of synovial fluid. So we're taking that filtrate and adding that hyaluronic acid to get that synovial fluid that's really important for these synovial joints. So if you've ever, say, pinched a nerve somewhere in your body, or if you've ever been hurt in one of your joint regions, probably the reason why you feel so much pain is because we have so many nerves in these synovial joints. And there's also a lot of blood vessels that occupy this area too. And again, that's to provide the basis of that synovial fluid, because synovial fluid is just a filtered part of the blood plus that hyaluronic acid. So probably something that you'll have to do on the exam, we may even do it as part of lab if you're in lab, is you'll be shown a picture of a joint and you'll have to decide, hey, how do I tell if this is a synovial joint? Is this a synovial joint? So what you should ask yourself is, first of all, is there a synovial cavity? If the answer is no, then it's not a synovial joint. Then ask yourself if there's any movement. If there's a slight amount of movement, there's potential that that could be a type of cartilaginous joint, right? We talked about those symphyses, that we have a little bit of movement there. But our synovial joints are going to be the only freely movable joints. So again, check for that synovial cavity, right? And ask yourself if there's any movement. So another thing that I want to mention are these bursae and tendon sheaths, because some of our synovial joints are going to have these. They're not strictly part of synovial joints, and they're not listed as one of those general features, but they can be associated with them. So these bursae and tendon sheaths are going to essentially function as ball bearings to reduce the friction between adjacent structures during joint activity. So these bursae, so you can see here in green, bursa right here. Bursae is just the plural form of bursa. Bursae are going to be flattened fibrous sacs that are lined with synovial membrane inside, and they contain a thin layer of synovial fluid where the areas are going to rub together. The tendon sheaths are going to be elongated bursa that are going to wrap completely around a tendon that is subjected to friction. Kind of think of it like a bun going around a hot dog, right? And this is very common where the tendons are crowded together in narrow canals like the wrist. You can also see that here. This is showing you the frontal section through your right shoulder joint. You see a bursa up here, the subacromial bursa, but right here you see that tendon sheath. Notice how it wraps all the way around this tendon of long head of the biceps brachii muscle. Wraps around it. It literally looks like this tendon looks like the hot dog, and this tendon sheath looks like the bun going around it. So these, if we look at some of the other features of synovial joints besides these bursae and tendon sheaths, we can also have what are known as fatty pads. I don't see Yeah, I don't see any examples on this one. But the fatty pads are going to be for cushioning between the fibrous layer of that capsule and that synovial membrane or the bone. And then we also have articular discs. This one you've probably heard of, menisci. So the articular discs or menisci are going to be where fibril cartilage is going to separate the articular surfaces to try to improve the fits of both of the bone ends. That helps to stabilize the joint and reduce wear and tear. So essentially it acts like a cushion to allow it to form into the socket more. Kind of like if you put a washer on a screw, right? Just allows it to improve that fit just a little bit more there. So those are some more kind of features of synovial joints, not necessarily always there, but they can be there. These bursae, tendon sheaths, fatty pads, and the articular discs or menisci. Moving on now, there are some different factors that are going to influence how stable a synovial joint can be. And they kind of go up in importance as we go up in number here. So the least important is number 1 here. This is going to be the shape of the articular surface. So it plays a very minor role. So shallow surfaces are going to be less stable than the ball and socket surfaces. So this articular surface, if it's large and it fits nicely together, or when that socket is deep, we see that stability is improved. And again, an example of this would be the ball and socket joint of our hip. But again, this is going to play the most minor role in terms of influencing the stability of our synovial joints. So the size, the shape of that articular cartilage. Secondly, we have the ligament number and location. This plays a limited role, plays more of a role than the shape of the articular cartilage, but not as much of a role as muscle tone. So ligament number, the more ligaments, the stronger the joint. So again, the more ligaments you have, the stronger that joint is going to be. But if you put too much on them, those ligaments can stretch, right? We talked about that with double jointed people, and they can stay stretched until eventually they just snap. And that joint is not stable if it has to rely completely on that ligament. So it can help to increase the stability, but it's not the most important factor. The most important factor influencing the stability of synovial joints is actually muscle tone, because muscle tone is going to keep the tendons taut or keep them stretched out and tight as they cross the joints. So it's extremely important in reinforcing your shoulder and your knee joints as well as the arches of the foot. So muscle tendons that cross the joint are going to be the most influencing or most important stability factor. Muscle tone is going to be defined by the low levels of contractile activity and relaxed muscles that are going to keep the muscles healthy and ready to react to stimulation. So this is very important again for reinforcing our shoulder and knee joints as well as the arch regions of our feet. Next, we're going to move on to looking a little more at the movements of these synovial joints, because again, all of these synovial joints are going to be diarthrosis, so they'll be freely movable. So all muscles are going to attach to bone or connective tissue at no fewer than 2 points. They're going to have at least 2. And those 2 points, you probably heard them mentioned before. You have your origin. This is the attachment to the immovable bone. And your insertion. This is the attachment to the movable bone. So muscle contraction is going to cause that insertion to move towards the origin. And movements are going to occur along transverse, frontal, or sagittal planes. So because with every bone, there's a bone that moves and doesn't move, that's again going to be the difference here between the origin and the insertion. So origin is attached to that immovable bone, insertion, attachment to that movable bone. So here are the different types of movement that are going to happen within the synovial joint. So again, these movements are going to be around an axis, right? So the range of motion allowed is going to be non-axial. Those are going to be slipping movements. Uniaxial, this occurs in one plane because uni means one, right? Biaxial, bi means two, so these movements occur in two planes. Multiaxial means in or around all three planes of movement. And there are three general types of movement that we see. We can see a gliding movement, angular movements, and rotation. So our gliding movements are going to be things like moving our wrist from left to right, right? There's angular movements, which are things like flexion, extension, and hyperextension. So flexion would be, say I'm keeping my head down. That's going to be flexing my neck muscles, right? That's flexion, and then extension is going to be keeping my head upright. And then hyperextension, it's a little painful, right? You move it past that point of full extension. It's uncomfortable, that's going to be a hyperextended movement. And they're meant to be uncomfortable because you're moving it past that normal area. So that's going to be the difference between your gliding movements, you're just moving things back and forth. Angular movements are going to be things like your flexion, extension, and hyperextension. Angular movements can really be any type of movement where there's a lot of bending. That's usually angular movements. Even flexing your arm would be an example. Flexing is moving it forward, and then extending it, moving backwards, and then hyperextending could mean putting it all the way back, right? Rotation, this last one here, is going to be like doorknob movement, literally, right? So rotating your joints, so rotating my wrist, right? Completely rotating it. I can rotate my leg in a similar fashion, right? That's rotation. I can rotate my head. So those are all going to be rotational movements. So again, we have these three general types of movement. We have that gliding, where things are moving from right to left, right? Angular movements, things like flexion, extension, hyperextension. And then in terms of rotation, it's literally rotating whole joints, right? So those are those three general types of movement. So I showed you a figure rather similar to this one right here when we started talking about synovial joints. And I mentioned that there were really 6 different types of synovial joints that were based on their shape. So I'm going to talk a little more about those now. Also know that there's a really good figure in your e-text, I think it's figure 8.1, that really walks you through different examples and talks more about these types of synovial joints that are based on shape as well. So first of all, we have these plane joints. And the plane joint, you see right over here in D, and it's showing you the example between your tarsal bones here. So plane joints are going to allow gliding or sliding movements between two bones whose surfaces are flat, like again between the tarsal bones here, also between the carpal bones. These are going to be non-axial movements. Then we have our hinge joints, which you see here in B. It's showing you the example of an elbow here. Hinge joints are going to allow for angular movements, and these are going to increase or decrease the angle between two bones. So this allows for some of the angular movements that we talked about in the previous slide. So flexion is going to decrease the angle between two bones. So the example I like to use for flexion here is you bend your elbow, right? So that's going to decrease the angle between your humerus and your radius and your ulna, right? That decreases that angle. We also have extension where we're going to increase that angle. So that's going to be straightening your arm back out, right? Then we have hyperextension where we're going beyond that point of straightening out. We're hyperextending that. We also have movements such as abduction. This is where you raise your arms away from the body, moving away from that plane of the body. That's abduction. When we bring our arms back to our body, that's going to be adduction. So these are all going to be uniaxial movements. That's what we see with these hinge joints. Then we have these condylar joints. So you can see that one right here in E. The example it's showing you is between the radius and the carpal bones of the wrist. And these condylar joints are going to allow biaxial movement, so movement in 2 planes. And again, they're found in our wrists. They're also found in our toes and fingers, so such as allowing our fingers to bend. That's a type of condylar joint. Then we have our ball and socket joints. So that's shown here in F. It's showing you the hip joint as an example. I think maybe that's the type of joint most people are familiar with. That's what they associate joints to be, but that's not actually the case for all of our different joints, as you're learning, hopefully. So ball and socket joints would be things like our hip and our shoulder. They're going to allow that rotational movement, right? You have multi-axial movement, but because it's more flexible, as we've talked about, it's less stable, it's going to be more fragile. So we see a lot of shoulder and hip injuries due to the flexible nature of these ball and socket joints. Then we have our saddle joints, which you see here in C. The example that it's showing you is between the trapezium carpal bone and the first metacarpal bone. The 2 surfaces on that saddle joint, if you look closely here, you can see one is concave, one is convex, so they kind of fit together. They're opposing surfaces. A good example would be our opposable thumbs, right? And then that 6th type of synovial joint is going to be our pivot joint. And the example shown here is between C1 and C2 vertebra, right? So our pivot joints are going to allow uniaxial movement, so in one plane. So things like supination, where I turn my palm forward, and pronation, where I turn my palm backwards, right? That's that uniaxial movement. That's a pivot joint. So again, 6 different types of synovial joints based on the shape. The plane joint, hinge joint, pivot joint, condylar joint, saddle joint, and ball and socket joint. And again, check out, pretty sure it's figure 8.1 in your e-text. Does a really good job of summarizing this as well. So in other ways to kind of help you learn a little more about joints, because it's hard to fit the whole chapter 8 into just one lecture, we have the Pearson's MyLabMastering.com. There are, on here, if you click on study area, look at animations and videos, click on A&P Flicks, and then scroll down to A&P Flicks for chapter 8. That's a really good resource for you to understand joint movement a little more. It'll actually show you those animations, something that I definitely can't do, especially in this virtual format. But even in a lecture, it's hard to show you that joint movement the way that this video can, because it can show you that at the bone level. Whereas if I tried to show you, we'd have skin in the way, right? So definitely check this out. I'll also make a note on the Lulima page to check this out as well. But that should help you learn a little more about the actual movement of these joints. So we're almost to the end of this lecture. On the last 2 slides, what I'm going to do is show you this table from your e-text. It's going to kind of walk you through the different joints that you should know for this course. Again, if you're in lab, you're going to see more of these, get more practice with them. If you aren't in lab though, definitely make sure that you know this table. Start making those note cards, whatever you need to do to start learning the names of these different joints. Thankfully, a lot of them are going to be named based off of the bones that they are articulating, so that kind of helps a little bit, but we're going to walk through those different joints that you should know. Okay, so this is table 8.2. Very scary looking table. What this does is it looks more at the structural and functional characteristics of the body joints. So it tells you first the joint name, right? Then it tells you the articulating bones. It tells you the structural type, and it tells you the functional type. So in other words, the movements that are allowed. So this first one in our skull, we talked about the only type of joints that we have there are going to be those sutures, right? So those are fibrous joints. Then we have our temporal and our temporomandibular. That should sound familiar to you, right? We talked about the TMJ joint, right? In our mouth before. So that's going to be a type of synovial joint. Then we have our antlo-occipital. So that's where right at the base of the skull here. That's going to be the occipital bone and the atlas. That is another type of synovial joint. We have our anteroaxial, so that's where C1 and C2 are going to come together. That's synovial. Intervertebral, that's cartilaginous. It's type of symphysis. We actually talked about that today. We have an intervertebral down here between the articular processes. That's going to be synovial. We have our costovertebral. That's going to be synovial as well. Sternoclavicular, synovial. Sternocostal, that's going to be cartilaginous. And we have the first one, and then we have the second one as well, but it's also synovial. We have our acromioclavicular, that's synovial as well. Our shoulder, I've talked about this one a little bit before, the glenohumeral, because you have that glenoid cavity where it's meeting up with that humerus, right? That's going to be a type of synovial. Your elbow, now we talked, that's a type of synovial hinge joint, right? Our proximal radial ulnar is a type of pivot joint, right? Our distal radial ulnar is another type of pivot joint, so synovial, right? Our wrist is going to be synovial, it's going to be condylar. Talked about some of these already today, right? Intercarpal is the synovial plane. Mentioned that one as well today. Carpal metacarpal is synovial, it's a saddle joint. Our carpal metacarpal is synovial plane joint again. Metacarpal phalangeal, or that knuckle, is going to be a condylar joint. And then the interphalangeal, or the finger, is a hinge joint, right? So some of these you'll notice we actually talked about as we went through the lecture today. It wasn't me posting a picture of that joint and saying, know this joint, but we talked about it and the type of joint it is, and now you see it coming back up here on the table. So we're going to look at the rest of this table on the next slide and look at the rest of the joints that you should be familiar with. But hopefully it's not as overwhelming as you start to look at it and you're like, oh, we talked about that. Oh, we talked about that back when we were talking about the appendicular skeleton. So I know I mentioned that glenohumeral, right? The shoulder joint. A lot of these we've talked about before. You'll see them in lab, whether it be virtually or in person. Maybe you've already taken lab and you've seen it, or you're taking lab next semester or some other semester and you'll see it then. But this looks overwhelming. Once you start to break it down, it's really not as overwhelming. Definitely, if you are short on time, I would make sure that you know the name of the joint and know what bones it contains as well as what type it is. So even if you just know whether it's fibrous, cartilaginous, or synovial, that's a key thing to make sure that you are remembering. So here is the second half of table 8.2. This is focusing on the lower part of our body, right? Some of these we've talked about as well. So we have our sacroiliac. This is where that sacrum and that coxal bone are going to come together right there. Then you have the pubic symphysis. We talked about that today, right? It's a type of cartilaginous. We have our hip or coxal bone. Told you that was a ball and socket type of synovial joint. We have our knee, which is synovial, right? So different portions of the knee, right? We have our tibiofemoral, our femoropatellar, and that's, like I said, just based off of what bones are coming together, right? Femur and tibia, femur and patella. Then we have our superior tibiofibula, so that's where the tibia and the fibula are coming together. We have the superior as well as inferior of that. We have our ankle, which is another synovial hinge joint. The intertarsal is a synovial plane joint. Tarsal-metatarsal is synovial plane. Metatarsal phalangeal is a condylar synovial joint. And then we have the interphalangeal, or that toe, is a synovial hinge joint. So again, not as overwhelming, hopefully, when you start to break it down. Definitely start to make those note cards, do whatever you need to start studying these now. It will definitely work to your advantage that you're not trying to learn these the night before the exam. It's also going to help you in lab as well. It'll help you if you go on especially if you're going into clinical practice or something like that. It'll be really important to know these different joints. And again, they're not so difficult if you've learned the bones that you were supposed to learn back from chapter 7, right? Because those bones, where they come together, they articulate, they're often named for those bones. So that should make learning these joints that much easier. That being said, that is all for chapter 8 on our joints. The next time I see you, we will be starting chapter 9. So I hope that you learned more about our joints and you learned that they're not just the ball and socket joints that most people are familiar with. It's so much more than that. And I thank you so much for watching, and I'll see you next time. Mahalo.